ground round speaker today, Dr. Christine McDonald. She's known very well to the department by everyone, particularly in her relatively recent role as the vice chair of our research, and is really involved with the R25 and the summer student program. As many of you know, she's a leading national and international researcher in the TBI space, specifically, imaging correlates and longitudinal outcomes in military personnel following TBI. And she has a 10-year funded study known as Evolve 10. She has an incredible first author New England Journal article on the detection of blast-related traumatic brain injury in the U.S. military personnel, which has been cited nearly 700 times since its publication. And she's also engaged in a number of other projects, including research for dementia. And we mentioned the R25 undergraduate summer student program, which she's co-PI with Dr. Ellenbogen. She's currently involved in 11 active grants. And she's young enough where she doesn't have any past grants yet, because they're all been funded for so long and so well. And she's also a PI or an MPI on 3 R level NIH awards currently. I'm embarrassed to say I've known Christine for a long time, but I don't know a lot of her personal interests, other than I know she's never attended my annual summer hike. So I'll just put that out there, as maybe someday that status will change. But other than that, thank you so much for speaking today. We really look forward to your presentation. Thank you.
Thank you so much, Dr. Kim. That was very kind, Louis. Yes, personal confessions. We take in rescue animals and furry 4-legged ones, and they just don't make it 13 miles. And we try to hike with them, not without them. So you are correct. We've actually often hiked in solidarity with you guys that same day when you guys are headed up. But yes, hope to make it someday. Maybe we'll have some that go the longer distance. Well, I'm going to go ahead and share my screen and we'll get started. Thank you all for joining today. Let's see if this works. What I figured I would do is actually kind of hit some highlights from a variety of our studies and do this more of like a lessons learned and thoughts and considerations for those engaging in research. And with that, as you heard, yes, much of this will be from the work we've done with U.S. military, as well as from studies with aging, and our neuropath colleagues, a couple of which, thank you, Dr. Keene, for joining so early, are on with us today. So I figured we'd start in the context of post-traumatic neurodegeneration, something that, while I think about it and many folks in neurotrauma think about it in the context of brain injury, I would submit that as neurosurgeons that you would be thinking about this too, because every procedure, every intervention, there would potentially be consideration of cellular molecular changes that can set things into motion that I think we all still need to learn more about. And then talk a little bit about work we're doing within aging, and then finish with the radiological pathological work that we do with the neuropath core. So as mentioned, I happen to run this Evolve study, and it's been going since 2008. I registered the clinical trial then, I can't believe it, and here we are today. And this was really focused, grants that have been awarded over the years to support this work. Actually, that's probably one of the lessons learned. Is surprisingly, 3 to 5 years goes by really quickly, so you have to write a lot of grants to keep things going. But really, the Evolve study and where this came from was a consideration that a lot of work had been done in veteran populations, but it was really unclear, what happens when you followed folks over time as pertains to clinical outcomes, imaging measures, and then still an outstanding question, and something actually with David Koppel, Dr. Koppel, we're certainly looking at now, which is, are veterans truly representative of active duty US military? Can you use that information and to inform outcomes of those that are still serving? And so as combat and conflicts continue to remain front and center in our kind of world view, and will probably do so, we thought it was important to better understand trajectories over time. And vast majority of this focused on mild traumatic brain injury because it became so prevalently identified in-service members deploying to the combat theater. Years ago, we started this at Longitudinal Regional Medical Center. We also worked at Kandahar Airfield and Camp Leatherneck in Afghanistan. And then the service members that we saw, we actually followed them back into the United States for 1 year, 5 year, and now 10-year outcome. And before I lose whatever level of residents are, in fact, at least pretending to listen in and might need a page and go save somebody's life, fine, go save a life versus listening to my talk. All right, priorities. I just also want to give a shout out to say thank you, because we are the weirdos that are up there on Sunday mornings very, very early, 2 weekends a month. And so you might see me, my team, and others walking around with service members, because the space we used for many years has been taken out by construction. And the boss very generously said, you know, we'll make this work. We'll give you some space to use on the weekends where you can quietly come in, as these individuals don't do too well with crowds and noises. So what does EVOLVE stand for? I have to remember too, when you write grants, you have to have a catchy acronym. Turned out it became a name that was quite appropriate for the study, but it stands for Evaluation of Mild TBI Long-Term Outcome in Active Duty U.S. Military and Veterans, where we in fact actually follow individuals during their time in service, and now individuals that have separated from service to appreciate long-term outcomes beyond the standard 6 to 12 months that many of us would always look at in mild traumatic brain injury. So this is a concert diagram. This keeps getting bigger and more complicated, but I'm proud to say that in the beginning, I was told we wouldn't scan anybody, and we actually scanned almost 600, and that this is a mix of both traumatic brain injury groups and 2 control groups, and that each wave we get about 350 in, although we are starting to lose folks. Now at the 5-year wave, we have a variety of individuals that are deceased. This is actually largely from dying by suicide, and this actually informed and motivated some of the neuropath work we do to this day. The 10-year wave is still underway. We have 194 patients that have made it in thus far. The pandemic, we were forced to take a pause, and that is because the vast majority of these individuals, because of where they started when they came back to the United States, don't actually live in Seattle. We have service members in the study in all 50 states, 2 U.S. territories, and it bounces between 7 and 9 countries. These people are flown in to Seattle for these workups. So unfortunately, we had to take a pause, but we're back at it. What happens when we see them? We do a battery of imaging. We do a comprehensive set of evaluations for neurological and neurobehavioral conditions, psychiatric conditions, and a 2-hour cognitive test battery for traditional measures of neuropsychological assessment that are done in rehabilitation and traumatic brain injury clinics. And so by following folks over time, we have the opportunity to compare what they look like as we see them and truly as they evolve through our follow-up waves. So I just want to give you a flavor of what we've observed. First and foremost, right off the bat, it was quite striking to see the extensive levels of global disability identified across all of our service members, both within the traumatic brain injury and even the combat deployed, even non-blast control group, which the blast control is essentially like an orthopedic trauma control comparison. And it didn't matter by mechanism, but there was extensive amounts of global disability and much higher than what had been reported for mild traumatic brain injury, even with polytrauma from our TRACK TBI cohort of level 1 trauma centers here in the United States. So something is different about these injuries and exposures. What was most striking is that when we followed these same individuals out to 5-year follow-up, not only did they not look so hot at 1 year, in fact, 64% experienced substantial decline from 1 to 5 years. Now, this is key because the vast majority of our clinical trials, our observational studies, and much of how many of us were trained was that, 6 to 12 months and you're basically stable. The vast majority of, recovery, rehabilitation is going to be in those early phases, and then you kind of, have the rest of your life that you manage. And this really brought to light that these things are not stable, at least in this population, and also can considerably decline after that kind of key 6 to 12 month mark, really motivating the consideration of longer term follow-up to better appreciate and understand the impact of these injuries on at least this particular patient population. Where did much of that global disability come from? Probably no surprise. It came largely from psychiatric conditions observed at the same time. It actually wasn't related in particular to, cognitive impairment, which you'll see in the next couple of slides. And these dashed lines show you where the clinical cutoff is from moderate to severe, both post-traumatic stress as well as depression symptoms. These were clinician administered structured interviews. We also do self-report questionnaires, but even at 1 year, very high levels across the board. And that unfortunately by 5 year, we're seeing that decline as well on these measures of both post-traumatic stress. And there's a lot of data on this slide, but it is just to say that, it's not just PTSD in the military. I think people focus on that a lot, but there's, other things like anxiety to consider, there's, mood disorders to consider, sleep impact to consider, but it wasn't actually driven by alcohol misuse or abuse. And that's an important consideration from prior conflicts. I think there's an expectation that there's a considerable amount of drug abuse, alcohol misuse that certainly happens. But in these early years, it was not driving this. And most striking was that the vast majority of individuals, 80%, over 80% in our groups of concussion and controls, and then about 50% of the combat controls, in fact, endorsed seeking help, trying to reach out to get help for the struggles that they were facing, but only 30 to 50% each group found sustained resolution. So that means that we're failing half or over half of our service members in our traditional mental health treatment methods. And the question was why? Where is this coming from? These work in other individuals. It's never 100% success, but they clearly have shown efficacy and are the standard of care. Why are things failing here? So we'll come back to that, but I do want to also highlight, as mentioned, that the neuropsychological test performance, interestingly, was not the driving force 1 year or 5 year follow-up. And the only things that actually pulled out were, in fact, actually measures of motor, fine motor and gross motor done at the time of the cognitive assessment. So that, in contrast to more moderate to severe traumatic brain injury, where there's a lot of focus on cognitive performance measures and cognitive impairment, that really is not the basis here of the impact. It's much more psychological and somatic in the context of these more mild brain injuries. So where could those changes be coming from? Well, maybe they're coming from in the brain itself. Although this slide, if I haven't lost you already, shows you all the imaging findings identified from conventional MRI, read by a board certified neuroradiologist at every time point for every service member, every scan. To be clear, we actually found no abnormalities consistent with pathoanatomic lesions for traumatic brain injury. And we found a Chiari, you got someone with a unknown vascular malformation, but there's no multifocal microhemorrhage, there's no contusions, you name it. So then we obviously then asked the question about advanced neuroimaging, and could that help us understand this evolution observed from 1 to 5 years in the clinical presentation? Are there changes in the brain, right, contributing to this outward change in behavior and function? And for that, I'll just quickly show you some of the summary findings that we observed when we used diffusion tensor imaging as well as quantitative volumetrics to understand if we were seeing, frank atrophy, right? Shrinkage of the brain disproportionately in our TBI, as well as a multitude of white matter tracks for looking at microstructural changes that had been previously reported following traumatic brain injury in general. These graphs show you the number of abnormalities in each of the domains. So the number of volumetric regions, the number of diffusion regions that were abnormal. And what you can see is that the diffusion right off the bat is picking up a lot of individuals having a lot, in fact, that's a lot of brain regions, white matter abnormalities, but no frank atrophy, at least in the subacute phase when we initially saw them. If we go out to the 1 year mark, we see something quite encouraging, which is, hey, it doesn't look like this is flat line. So there's no brain volume changes per se, but in the white matter microstructure, we're actually seeing encouragingly what would be interpreted as some sort of resolution or recovery in those microstructural alterations. occurring at the time of injury. Great. Okay, the brain is getting better. Maybe that's good. Now that doesn't explain the outcome measures, but it does help us in trying to appreciate what happens over time, and hopefully suggest that there's some kind of resolution that's occurring. If we go out to 5 years, what we see is a flat line on the diffusion for our for our non-blast controls, so that this just is the sanity check of there is not something that is just because of combat deployment, for example, that is altering brain white matter microstructure over time. And there's not frank atrophy that is occurring in these individuals over time. But look what happens with the diffusion. We essentially end up with a U-shaped curve where it's not everybody, but a proportion of these service members are having what would be considered a delay onset of additional microstructural changes occurring in their brain. Now you have to understand that these values are corrected and adjusted for age, education, sex, including interim head injury exposures, because the argument could be, well, this is just because they've had further head injuries. Head injuries are a risk factor for further head injuries. Clearly, that's where this is coming from, but we've corrected for that. So this is after you adjust for that, there is a set of individuals that are having continued alterations at the microstructural level that at the 10-year now, we hypothesize that these folks would then go on to have frank atrophy. And so to kind of, summarize this initial vignette of information, 15 years of findings in 20 minutes, of course, it all makes sense. But just to be clear here, what this is really saying is a little surprising for this group. It wasn't appreciated that there would be considerable change over time, and that even something as, mild, even though there's nothing mild about it, as combat concussion appears to worsen things like global outcome, that it seems to exacerbate mental health symptoms in ways that are disproportionate to those that just combat deployed. So it's not just that, the exposure, the potential trauma of combat, there's something else going on here. And that it was striking that so many attempted to seek help, but that so few, in contrast, truly had sustained resolution. And that perhaps that might actually be getting compounded by things that are happening both under the hood in the brain itself, and that we are actually seeing from 1 to 5 year follow-up a proportion of people with worsening secondary decline in actual brain microstructure on imaging, something that we could potentially even use in life to better appreciate this. But if all we had done is seen that person at 5 years, we would have no understanding that that was different and distinct from 1 year, or different and distinct from subacute. And that the other piece to this is that oftentimes we, in observational studies and clinical trials, lump chronic as anything over 1 year. But this would really argue that at least in this population, you should not be lumping 1 year and 5 year, because there are distinct differences, and that things truly do continue to evolve. But this really begged the question for us is, there's many studies that suggest that early head injury exposures, or head injury exposures in fairly early adulthood and adolescence, impact us later in life and lead to potential risk of various forms of dementia. So could what we're seeing actually be the earliest evidence of how head injury exposures may connect to that later life neurodegeneration? This was really an outstanding question for us. Clearly, there is an evolution, not resolution, of symptoms, but also imaging. And this really brought us to thinking more about aging, because this would suggest that even these, truly they met the clinical definition for concussion. They were mild, uncomplicated traumatic brain injury individuals. That this would have important implications as this population ages. Please do keep in mind that one of the things that I would find biased, of course, but I think is important about understanding this particular patient population is that service members, as they separate from service and become veterans, the primary medical care oftentimes is VA. Now they have to apply for that. Not everybody applies for VA benefits, I recognize, but vast majority do. And VA benefits are covered by us as taxpayers. So even if you don't care about what I'm saying, you should care about this as just fundamentally as a taxpayer, because the health care for these individuals becomes our burden. They served us, now we need to serve them. But we can all be more efficient about this if we better understand these things, because those disability payouts are shown to actually increase decades after conflicts end. And in fact, OIF, OEF, and OND to date are showing trajectories that they will near $1 trillion a year in disability payout in the next 10 to 15 years. And so there is real reason that we need to better understand this. But we started thinking more and more about aging. And for that, I'd like to switch and talk about lessons learned from the ACT study. I reached out to Paul Crane, who's a general internist and one of the PIs of ACT years ago. He kindly, too, became a surrogate mentor of mine when I joined UW about 10 years ago. And, we started talking about aging, and I was like, Paul, what do you know about, brain imaging findings in your community-based cohort? Because I thought, surely that's, a great control cohort. We'll figure out, what baseline should be, and then we can back out what, you would expect for people with, different forms of head injury. And there are people in ACT that served in various conflicts and have military history. So it was a unique opportunity to try to better understand this. But the very fundamental question was just, are the people in the studies that we're doing, are they truly representative of the patients that we're trying to serve? Are the service members involved representative of the deployed force at the time? We checked that. Yes, that does hold. But this question of, who you research impacts the recommendations for future selection of therapeutics, but also future selection and determination of further studies and what we should go after. And so for those who are not familiar, and right, these are the grants that have funded this previously and currently. The Adult Changes in Thought, as it's known, or ACT study, is actually a really unique cohort. And I encourage anyone that has questions about conditions of anybody that's 65 years or older to check out ACT. This has been in place for over 30 years. And there are over 5,000 patients in the ACT study. And essentially they enroll individuals that are 65 years or older, cognitively normal at the time of enrollment. So unfortunately, this would, preclude many of the folks that we're seeing because they would be impaired before 65. But this is why this should be, the cleanest of the clean, the creme de la creme of the aging community cohort populations. But what's extraordinary about these individuals is that their enrollment, what they're consenting to, is complete release of their medical records. And they often also consent for brain donation. And then every 2 years, they have these comprehensive research clinic visits. But on average, they will have anywhere from 25 to 35 years of medical record information on these individuals, every pharmacy fill, every lab order, every clinic visit, hospitalization, you name it. But what was interesting is there wasn't actually a ton out there yet about what they had as far as imaging. And so Paul and I got talking, and we thought, this would be something we should look at and better characterize to better understand, how this would inform these questions of early head injury exposures relating to later life varying forms of dementia. And, could we go after that? And they had published some work suggesting that those that were cognitively normal, their risk vectors for, if they had early life traumatic brain injury exposures, were more in the line of like Parkinson's disease versus other studies that when they see people who are demented in their 50s, for example, with traumatic brain injury history, where they reported out that they're more likely to have Alzheimer's disease. And then there's now even a kind of ALS story that's being told. Clearly, there's a chronic traumatic encephalopathy story that's told. And we're trying to better understand why certain individuals end up with these conditions following these life's exposures. But to say this study is extraordinarily rich because for any question you ask, you can look at decades of information on them. So we decided to go after the imaging available in these individuals, both in their clinical record, but then some of them had been part of research studies. And then we figured, well, we'll continue to do research scans because surely we can, learn as much from both than one versus the other, meaning just the clinical MRI or the research MRI. And historically, clinical ordered exams couldn't be utilized for research because they were all over the map. But it turns out that there's been a lot of work to be done that standardized how you could use those scans. And in fact, many of us were part of NIH initiatives to develop what are now called the neuroimaging common data elements, ways that you can reuse essentially clinical exams. Because the argument was, well, some of those individuals would have already died. Some of these people are medically unstable. You can't bring them in for research. And you're trying to better inform and make decisions about their brains and brain pathology, really. And so the ACT Neuroimaging project at large was kind of born. And over the past handful of years, we've actually procured over 2,000 MRI scans from ACT participants and completed the CDEs with a group of board certified neuroradiologists. They then go on for quantitative volumetrics. In this day and age, you can make a synthetic MP-RAGE if one doesn't exist on the MRI scan. And I have a team of image analysts that are rapidly going through these 2,000 MRI scans and conducting analysis on that. And then, as mentioned, there were some prior research scans. We are continuing new research scans that have all kinds of quantitative and advanced sequences. And interestingly, as mentioned on the previous slide, many of them will consent to brain donation. And we've actually set up a postmortem imaging arm that we do in collaboration with our NeuroPath Core. And so that we have both imaging in life and after death on these individuals. And I'll come back to the postmortem imaging here in a little bit. But fundamentally, the question became, how do those who come for research MRI compare to those with clinically ordered MRI? This is like the most basic question, but it became incredibly profound because with the ACT study, they're all out of Kaiser, formerly Group Health. We had 3,000 in one group. We have 1,000 in another group. So we also have the just sheer power of sample size here that we can look at. There are hundreds, and these numbers get small fast. I want to acknowledge that, but that this is quickly growing, and these seem to hold. And what was surprising is that even demographically, mind you, all of these individuals that represent this table are actually already from a research study, but even within a research study, those who came for the research imaging were slightly skewed. Even on demographics, they were largely more white, they were largely more educated. And I know a lot of people say, well, you can just make adjustments for that and that's fine. But can you? Does that really still help inform this group here? This is the group. This would be anybody who comes for clinical imaging. That's who you're going to place an order on. And if we find something that we're going to say, hey, let's translate into clinical care, it better match to the patient population that we're attempting to utilize it on. So the demographics were a little off, and again, some people write that off, but again, because of the richness of ACT, we can go into their medical records and look at a bunch of information about who they were from essentially a clinical profile standpoint. And it was striking to find that those who came for research, and this is a significance that has been adjusted for a bajillion things and corrected for multiple comparisons. These are pretty robust. That those who came for research, for example, were much less likely to have essential hypertension. They were much less likely to have cerebrovascular disease or congestive heart failure or stroke in the last year leading up to their MRI scan, or diabetes. These are much healthier people. And that starts to beg the question, are they really going to help us inform this population? And you could say, well, of course, people that get clinically ordered MRIs are going to be sicker, but we better understand that. And we better understand that in ways to understand transforms if we're going to be trying to inform, again, that population, because that's the target. We were also surprised to see that they had much, significantly lower dementia diagnoses, higher performance on cognitive measures. Even their overall medical morbidity was significantly lower than the group. Again, these are all from the same community cohort, but then the group that did not come for research MRI. They had less inpatient hospitalizations, again, much more exercise, good health overall. And so it was, clear that there is a misrepresentation here. If all we had done, if all we could see is this, we had the opportunity to see these other groups because the way that ACT has been set up, but not everybody gets that opportunity. And so again, these are the takeaways. What was, I would say, even most striking was that this impacted even at the level of the brain. And what do I mean by that? Well, this is the summary list of the common data elements that were reviewed and identified by a team of board certified neuroradiologists. And so surely if you're going to use research brain MRI on folks, they better have some association, or you better understand the differences in ways to then be able to translate that into your target population. Those who came for research MRI were significantly less likely to have acute infarcts identified. I realize that's no surprise. But even things like chronic hematoma, subarachnoid hemorrhage, subdurals were significantly lower. Hemorrhagic transformation, obviously, significantly lower in those who came for research MRI, and hydro even much lower for those who came. But what was probably even most striking of everything on the brain imaging side was that the brains themselves, the individuals who came for research MRI, had larger brain volumes than those who were coming for clinical scans. And this is where the rubber hits the road for the imaging side, I would say, which is that we are using imaging to date to try to do things like develop volumetric thresholds. In fact, there are FDA submissions right now that are looking at considering something like hippocampal volume cutoffs for future Alzheimer's disease clinical trials. But if you were doing that on individuals whose brain and brain anatomy is distinctly different from those who would be coming to get that scan in a hospital, your thresholds are off, and you need to know that. That would potentially have a major impact on who you give a drug to. So this has some significant fundamental implications here. And this is why I think it's important for all of us, when we think about work we do, to really think about the bias. We use the word bias, people throw this around, but really what that means, because research studies are heavily biased by those who come for research. And even in something that should have been the most, normal, mundane community cohort of aging, we're seeing that the subgroup that comes for additional studies, things like MRI scans, are in fact different on clinically important and actionable measures than those in the same study who just didn't come for those additional activities. And as noted, we saw differences in overall health, cardiovascular health, mental health, cognitive performance, and even brain imaging. And so this really, I would say, should motivate all of us that careful thought and consideration should be given to assure that your population truly matches the population you're attempting to serve. This even goes for retrospective chart review. I will submit to you. I don't think it's enough to say, oh, I just pulled the charts of the last, 30 diagnoses or the last 6 months. You really need to think about the population at large and how does that represent, because we oftentimes have demographic skewing and it kind of gets written off. But more and more, what this has shown us is that demographic skewing, saying, well, largely white, higher educated, really translates into health disparities as well. And I would submit that this exists for all populations, even within patient populations that our residents and our colleagues are attempting to pull information on. So something to keep in mind as you go forward with your own work. With that, I'd also then like to say that, part of what came up then was, well, we see these imaging changes with Evolve, we saw this stuff in life, but what does that really mean at the tissue level? And as I said earlier, after losing a variety of service members, mostly to death by suicide, I reached out to my neuropath colleagues, and I want to give a huge shout out to Dr. Keen. Dirk has been an extraordinary colleague and friend, and really thoughtful and open to considerations of how we can work together to help each other and better inform the true pathophysiological changes that are occurring in the context of, well, at the end is a truly cross-sectional study at best, but by linking to all this stuff that we have in life on these individuals, can we better inform the next generation of treatments, the next generation of patient studies even. And so this is where I shift and talk a little bit about work that I've done with these phenomenal individuals. You should get to know your fellow neighbor neuropathologists. They are brilliant. They are just wonderful, wonderful folk and incredibly hardworking and truly thought leaders. Dr. Nolan is the neurotrauma expert. Dr. Latimer is a dementia expert, and Dr. Keene is a all things expert, dementia, neurotrauma, and everything under the hood. And this also has been funded by a variety of studies over the years as well. The concept really is this, which is they get to see stuff at the tissue microscopy level, and that's fantastic. And we think of pathology as the gold standard for diagnosis. But in life, you know, unless you all have to pop out a piece of tissue, we don't really want to have to take out tissue. So is there a way that we could work together to better inform basically information back to something like imaging, because the imaging we could do in life, and that could help us refocus imaging biomarkers for various conditions. But the first directionality was the antemortem to postmortem, but now it's kind of like, and back again. And this is to say, can we use image guided tissue sectioning as a supplement to traditional neuropathological work, the workups that are done for the autopsy case sign outs, and can we, you know, leverage for a variety of these studies where we have, you know, serial, so longitudinal and, you know, fairly exquisite in life imaging. Can we use that to better inform even what happens after death? And so we embarked upon this initiative to essentially, for decedents, try to pull any imaging that there was on in life, co-register that to the postmortem scan, and then align that to the tissue slabs that they get sliced in coronal plane, which is why you're seeing these images down here, but also create a synthetic empty range to do some quantitative volumetrics along the way as well. This is the process. It is a little bit hard to see. These panels here show you every place that they take tissue blocks. A huge shout out to the autopsy teams. And to date, in fact, actually, we have done over 650 autopsy cases together. So we've been a little busy the last few years, but the Neuropath Corps is busy. They now do usually over 200 autopsies every year. When I started with them, it was, we'll probably do 125, 150, Christine, don't worry. Things have just continued to grow. But the way that they do this, they embed the brain in Agros, which allows us to actually scan it and scan it in the same orientation that they slice it. This is a modified deli slicer. At the end of the day, it's all protein and lipids. But what that allows is for some really nice 4 millimeter coronal sections to come out. But this is a great example of how we can help each other. So this coronal section corresponds to this level on the scan that was done on this brain. And as Paul Crane would say, you can see this very juicy white matter lesion. We need to inform our general internist colleagues that juicy probably should be used for something other than white matter lesions, but Dr. Crane is brilliant. And so I will give him that. But what you can see is that while we can see it very apparent here, it is not so clear on this coronal tissue slab. Now they'll go in and they'll feel these, you know, tissue slabs as they're laid out and try to inform if, you know, by palpating is something soft or not. But we can very easily see this. Now they can help us because while we can see, hey, there's this white matter lesion here, we have no idea if that is, you know, truly gliotic, if that's tau, if there's TDP43 proteinopathies in there, if there's some other type of pathology, if it's just demyelination. And that's where the tissue microscopy can help reinform what we are looking at on imaging and help us get more selective and specific about what these lesions, for example, may be. But I also want to acknowledge that they have done an extraordinary job of not just taking the traditional blocks, it's around 20 that they would take, for example, for aging and dementia. They take about 78 tissue blocks on the cases that are done not just with aging and dementia in mind, but with traumatic brain injury, and being open to trying to section areas that have been reported in the literature to be commonly injured in something that recognizing is a heterogeneous condition, as well as other areas as they pertain to functional networks. So you can actually map back, for example, the default mode network, if you're interested, attentional network, limbic network, you name it. And so this also allows us to link antemortem imaging findings out to postmortem endpoints. And this has been a unique opportunity to see progression over time in ways that, again, cross-sectionally is just not appreciated. This is an example of somebody with white matter lesioning that we've done this with, where not only do you see the level of white matter lesion load increasing, you see the ventricular volume increasing, which unfortunately becomes kind of, double hits to the total brain volume. But as an example, a way that longitudinal helps inform beyond cross-sectional. Interestingly, it also came to light that we have not always done the best job in imaging to appreciate impact of remote brain injury lesions. This was a case of a young man who unfortunately committed suicide. He was a bull rider, where we had multiple scans in life on him. He passed away in his early 20s. We did the postmortem imaging and then the brain tissue sectioning. And in life, there were situations where there were MRI scans done following injuries, and he had clear indication of like multifocal microhemorrhage, and then you see the scan a couple years later, and the note there says that it resolved, and that at postmortem, and admittedly this, for purposes of this publication, became the structural image, not the SWI, but at postmortem imaging, we could not see it either, but we had this co-registered. And so as an example, we went in and said, hey, we should probably block here as well. And it turned out that at the microscopic level, there was actually indication of chronic brain injury, in addition to areas that have pathognomonic lesions for chronic traumatic encephalopathy, and the tau staining, as you can see here. And working together, this case was worked up and signed out as actually low stage CTE with considerable amounts of brain injury lesions, that I think both of us, and I confirmed this with Dirk as well, that it would have been missed by traditional neuropath sectioning. They didn't initially section these blocks, and we would have missed it too on MRI. But by working together, we are able to identify a much more comprehensive understanding of what happened, and again, the progression over time. And the last thing I'll say about this one is that this also really opened my eyes, in particular, to what truly is multifocal microhemorrhage. I know clinically there is, the classifications for DAI, but working with our neuropath colleagues, they've really challenged that consideration. And there's now a couple very prominent papers on this in recent years where we're able to align this, that not always are those ditzels of dark blood on SWI truly representative of injured axons. In fact, there are one study showed that the vast majority of that's truly vascular injury and not axonal injury. And we really should be careful about how we inform the considerations of DAI. I do want to make a quick note on resolution, because part of the distinction and discrimination of why aren't we seeing this on imaging may in fact just come down to the limitations of our technology. I think most of you know this, but to be clear, and again, to put the significance back front and center, standard imaging, we acquire 1 to 5 millimeters at best, but the axons, the pathology, the neurodegeneration that our neuropath colleagues are looking at are on the order of microns. So that means that our standard clinical imaging is off by a factor of 1,000 on any given day. And I know, people say, oh, yeah, it's millimeters, microns. But it's like, but stop and think about what that means. That's like asking Google Maps. I was trying to think of, what's a way to put this into perspective. That's like asking Google Maps to find 20 miles of broken road, for example, by only looking at 1,000 mile increments. You can't see anything lower than 1,000 miles. Are you really going to confidently be able to see that? For a frame of reference, I had to look this up, but I'm originally from California. And so of course I went south instead of east, for example, but 1,000 miles from Seattle is Bakersfield, California. If all you saw was this, you're telling me, you know, how much do we actually really need to see? So if we see something on imaging, that's likely a lot of injury. You would need a lot of, quote, road disruption, if you will. And so again, in a takeaway lessons learned, I think a little caution should be given to how we comment and talk about diagnostic interpretation. Many, I think, are more thoughtful these days, but I have heard clinicians, not necessarily in our department, but I heard clinicians say, oh, your brain is healed. There's no longer injury. Oh, the such and such has been taken out. It's no longer there. I think in all honesty, the best we can say is that anything left is under the resolution of our imaging technology, or we cannot say anything, cannot see anything, and that's really encouraging. But you know that the reality is that there's stuff that can be much, much smaller. And again, this is just the where we are at with technology, and that's why we're pushing forward. We also do the segmentation that you can see here. So we get all kinds of volumetric information. And now we have this into a fully integrated platform. In addition to the ex vivo imaging, I purchased a hyperfine MRI scanner, and Dirk very generously let me situate it in the autopsy suite so that we get cadaveric imaging. We've now done this on almost 300 cases since I bought it back in October 2021. This is done because many of the autopsies they do are now done with this rapid protocol where half of the brain will be frozen in isopentane, so the tissue can be used for biochemistry. It gets sliced at the time of autopsy in dental alginate, which is kind of a minty flavor. So that's a nice smell in the autopsy suite. And then the imaging can be used for alignment of these kind of cortical regions, for example, now, not just from the scans, but back down onto the tissue itself, so that we get much better precision in our alignment, for example, of cortical regions for things like functional network mapping. So we've come a long way. And my last comment I will leave you with is that this is where the rubber hits the road, literally. For anybody that is still on and hasn't checked out, it turns out that if you do ex vivo imaging, that those things weigh about 12.25 pounds each. And we do this at Harborview, but we image them at UW-Montlake. So Dirk, the agreement was, okay, well, I will sign them out, we'll take them up, we'll scan them, and we'll bring them back. In doing this with them over the last couple of years, this means that I have personally schlepped over 8,000 pounds of embedded brain back and forth from Harborview to UW-Montlake. And we've done this over 75 Sundays. And so of the autopsy cases, the 668 that we've done to date, that means that I have driven brains over 600 miles, all in the name of medical research. It would have been shorter for me to drive, for example, to Calgary, Canada. Now, my husband jokingly used to call it the brain mobile. We recently retired our Chevy Spark, but for many of you who know me, you know I'm a commuter cyclist. So other things that Lewis Kim will now know about me, but as a colleague, most recently we retired it and we bought a Chevy EV Bolt. So if you see me on a Friday or a weekend driving along I-5 in an EV Bolt, not on a bicycle, it is likely because I'm transporting very precious organs of individuals who we're trying to learn as much about. So maybe give me a little space on the highway. And you just never know what's in someone's car. I hope to date, and it has not happened, I hope I never get pulled over, but it'll be an interesting conversation to have with the police officer when they say, open the back, ma'am. So with that, I'd like to thank a number of individuals. This is truly a labor of love of many folks here around the world over the years, and a lot of thought and consideration. I don't stand up here myself. I stand up here truly on the shoulders of giants who have allowed me to do this. And I just want to acknowledge and thank our service members, their families. We fly them in from all over the world to do these workups. It's a lot for them to come in. A huge thanks to the community aging cohort with ACT and the participants who we are so humbled to work with in life, and many who we actually see at the time of death as well, and they provide brain donation. So with that, I will take any questions, comments. Yeah, you can probably send me the complaints too, but I will stop there. And thank you so much.
Christine, thank you so much. Great presentation, and really also just great to get an update for what you're doing and what's going on. I think you're just a role model for our residents and a mentor, and we're really grateful for all that you're doing for the department on top of all this incredible research. So I'll open up the floor to questions. Nino, do you have a question?
Yes, Christine, very fascinating. Now, the GPS map was totally fascinating. Now, the question is, how can, let's say, default state measurements give you something about changes in, connectivity or something? And do you get better resolution when you look at, activity changes?
Are you talking about, you're talking about for the postmortem?
No. The living person, like whether basically if you do default state analysis, whether there you see abnormalities much more than in like white matter damage or something.
Oh, just in general.
Activity changes versus morphology, kind of.
Yeah. No, it's interesting, so, we have done some functional work, and most of that was led by a postdoc of mine. And they used a graph theoretical analysis approach. So, caveats of the approach, but it turned out that there were some alterations in default mode network and the default state, as you described, that did seem to evolve as well over time. And it was interesting that kind of those nodal relationships actually, to the point about diffusion, seem to be altered in ways that the underlying long-range connections that we saw with the microstructure seem to inform and explain, and was kind of like, okay, the functional as well as the microstructure are telling us the same story. But what's interesting is that over time, that has definitely been, again, an evolving story. And with the advancements in technology, to drill down a little bit further, it does seem that there are additional changes in things like just like the cortical gray matter of those nodal networks that we're now actually interrogating also with diffusion, but with the reverse effect. So the thought there is that there would be increases in anisotropy from things like neuroinflammatory response that might be part of the reason. So we see these alterations. So then the question becomes why? Why are you seeing those changes? Sure, there's functional stuff, there's microstructure, but what's the underlying, again, pathophysiological change? And I see Dirk on here as well. But our neuropath colleagues, largely this day and age, it really seems that it's inflammation, that there's a huge influx of inflammation, which in life, and I see Dr. Lozier's hands up, so I will stop here shortly, is just to say that, traumatic brain injury incurs a neuroinflammatory hit. Poor sleep, we know, incurs a neuroinflammatory hit. Our psychiatry colleagues show us that anxiety, post-traumatic stress, all incur a neuroinflammatory hit. So to me, I'm kind of thinking of it like a multi-hit theory, and that may be why we're seeing what we're seeing, and maybe why some of those traditional mental health treatments didn't work. So I will stop there because I see Dr. Lozier's hand is up.
Yeah, my question relates to the fact that there's increasing evidence that something as basic and simple as poverty is responsible for many of the diseases that we are plagued with. So have you looked at in your subjects the role of poverty or some analog of that?
It's a fantastic question. We did focus specifically on lifetime, and then every time we see them, incremental changes. So things that we are noting, and actually, unfortunately, in more recent years, as they've kind of backed off on the requirements to serve. So when you served, Dr. Lozier, there were higher requirements to enlist than there are today. Now they'll take, people with misdemeanors and whatnot. Unfortunately, yes, there is a disproportionate. Now this is across the service member force and largely enlisted, not officer, a greater historical preponderance of those individuals. They're in our study too. Homelessness at some point during childhood or adolescence, the misdemeanors, and then in the interim, and actually right now, one of my patient coordinators, she found one of the folks we're looking for, he's currently in jail, that there is a greater likelihood of these individuals to have run-ins with the law, but also other major life events. So we collect, have they been divorced, other major life stressors that will play a role in your outcome and disposition and your overall, feeling of quality of life even. And I'll tell you that, spoiler alert on the tenure wave, the other thing that's incredibly striking to me is just and it's disproportionate to the TBI, they just appear sicker at this point. Like we're collecting even BMI. One of my data analysts was like, I think this is wrong. You have the BMI is 43. No, that's right. That person's BMI is now 43. But remember, when they were deployed, everybody met those physical conditions, like, you know, they were of top shape. And then also, you know, now more people with a diabetes diagnosis, a hypertension diagnosis, sleep apnea diagnosis. So while you're right, it's poverty or a surrogate, we are thinking of it more kind of collectively as, you know, major life stressors and major physiological stressors, and that there may be something about that continuum, and that with all due, you know, respect to the theories about early life exposures, later life, it's probably actually a multi-step process. And I don't think anybody would disagree. It's just no one's ever carefully followed people from those exposures all the way out to figure out how they get dementia from those exposures. And we're just on the cusp of starting to see that. In fact, actually, we have individuals that have been referred to dementia clinic, and the average age of our individuals is in the 30s and 40s now.
Thank you.
Yeah, it's a great question. Thank you so much.
Other
You know,
questions?
oh, sorry. Louis?
Dr. Keen. Hi,
I was
Derek.
just
Yeah.
about to put you on the spot, Dirk, so I'm glad you're
Oh,
beating me to the punch, as they
I
say.
love being on the spot. Christine and I are on meetings like every day together. So I don't actually have much of a question. I just wanted to commend you for taking our neuropathology program to a whole another level. We didn't really even talk about some of the really new stuff we're doing with the Brain Initiative, and just the precision that's coming with these rapid imaging. We're the only group in the world doing this, and it's all because of Christine. It's just I just wanted to thank you in front of your department, because it is such a pleasure, and we wouldn't be anywhere close to where we're at if it wasn't for everything you do. So kudos. Thank you so much.
That is it is truly an honor. Thank you, Dirk. Really, I truly feel like I'm standing on the shoulder of giants, and you are really one of the giants. I will put the shout out to this community that, you know, what Dirk is referring to is, remember, that's not just trauma cases and aging old people, like the tumor repository that, unfortunately, sadly, you know, you guys fight hard for them in life, but not everybody makes it. That, you know, that is there as an opportunity for residents, for attendings who are interested in that tissue, interested in the imaging, interested in the data at large on those individuals. There are a lot of neurosurgically relevant cases, I would say, in there. And Dirk, I would also think about the spinal cords as well. And I know Ollie Robinpay and others have had interest in looking at some of those. But just as a resource, in particular, now with my vice chair of research hat on for the residents, that there's many opportunities here. And I know some of you have reached out to our neuropath colleagues about everything from, you know, traumatic injury states to other conditions, but just that is there. And it's a small group, but a mighty group. And that there's a lot of information that could be gleaned there.
Thank you, Dirk, for that comment. Very, very true, and we couldn't agree more with what you said. Are there any other questions? I just have a personal anecdote, but I just wanted to make sure that there were no science questions before I interjected. So even though Dr. McDonald is a PhD, what she's doing is helping patients. This is about, in the end, outcomes and improving quality of life. And one of my close personal friends is a retired military colonel who saw significant combat, TBI, and PTSD. And many years ago, I reached out to Christine for help for this really dear friend of mine. And without hesitation, she just, you know, found a path forward for him and got him on a program and a track where he could get the help that he needed. So I just wanted to remind everyone that this is not just test tubes and benchtop. This is about human beings, and it's incredibly important and incredibly real. These sorts of injuries don't just happen in the military. It's a great model, but it's certainly applicable broadly, generalizable to the entire population. So please don't forget that what she's doing is exactly what all neurosurgeons want to do, which is, help patients, help families, and improve quality of life. So I just wanted to have that parting comment, Christine, to thank you and for what you're doing on a micro and macro level, and really grateful to you being in our department and, really being a shining light for us to follow. So thank you.
It's an incredible honor, Louis, really. And I met with him, actually. I happened to be out that way for a couple meetings, and truly an opportunity. And yeah, the backstory, so that you have some weird thing to say about me in the future, is I grew up in a small agricultural area, and my last name is McDonald. So I literally grew up on old McDonald's farm. And thought I myself was going to go into the military, and got into the Naval Academy. I'm sorry, Dr. Lozier, it's so embarrassing to say this many years down the line, but had a knee injury, and life took me elsewhere. And it just became this kind of like, if I can't serve, I'm going to serve those who serve us. And that became my motto. I worked with an Army battalion in undergrad. I worked with the military out in St. Louis, and then I went and worked in Longitudinal and trauma surgery to see medevac casualties myself. Because that is the role that I just feel very strongly about. And that I think all folks who, in some capacity, whether it is as a clinician, as a clinical trialist, as a, clinical researcher, doesn't matter, you are there to help better patients' lives. And if I can play one small little role in that, then my job is worth it. It's important. So thank you all. I know we're right at 8 o'clock. You all have busy ORs to get to. And so thank you for your time and staying on.
Thank you, Dr. McDonald. Thank you, everybody, for joining us today. Appreciate it.
Have a great day.
Bye.